Hi, good day dear colleagues, I'm Dr. Jihad and our today's lecture is a continuation to the series that we have started, What Surgeons Should Know, and it's about anastomosis. And as a brief introduction to this lecture, actually in this lecture we are going more to concentrate on lower GI anastomosis. Of course, there is a consistent fundamental principles that can be applied to lower GI anastomosis and upper GI anastomosis. But I think that upper GI anastomosis require unique knowledge. For example, the anastomosis in the esophagus or in the stomach, bariatric surgery, etc. Okay, our today's lecture will be divided into two parts. The first part, we are going to talk about anastomosis in general. We are going to talk about the physiology of the healing of the anastomosis, and we will notice the differences of wound healing in the GI tract when we compare it to other sites. We are going to know some special, unique technique of mobilization of the bowel. And why is that? Actually, we will explain it in the next few minutes. Anastomosis is bringing two tubular structure that are apart from each other together, and so we need some releasing technique of the proximal and the distal segment. This what we call it mobilization technique. You will understand that when we get through this lecture. We will talk about the configuration, how we can connect these structures side to side, end to end, etc. We are going to talk about the methods we use to construct anastomosis, hand-sewn, staplers, etc. And finally, you will find the answer of what is the difference of green staple 60 millimeter from blue staple 80 millimeter is. So we will understand that. The second part of this lecture, we are going to talk about the complication of anastomosis. Okay, as we said, anastomosis is bringing two tubular structures. This can be the bowel, it could be the ureters, it can be esophagus, vessels, etc. But if we are talking about gastrointestinal surgeries, in the past 2 centuries, or in the 19th centuries, or 200s ago, the surgeries in the bowel was just limited to just bringing a stoma outside the abdomen, or what we call it exteriorization. And fortunately, with the development of the science, we noticed that when we connect two bowel together, we have good results in healing. And so the principle of anastomosis starts to develop. If we are interested about the terminology, so ana, as you see here, means without, stoma means mouth, anastomosis the status without a mouth, or reconnecting, as I told you, reconnecting two tubular structure together. Okay, you can see here in this picture when the surgeons starts to reconstruct anastomosis or deal with the anastomosis, actually nothing was easy. And you can see here, for example, the mortality rate. These are the dots here are the mortality rate. It was up to 100 in, for example, in 1877. So patients suffer enough until we reach the modern medicine today. Also, what I want to say at the beginning. Actually, anastomosis usually is the final step of intestinal surgery. For example, we are going to remove a segment of the bowel, diseased bowel, whatever it is, cancer, diverticulosis, bleeding, etc. So anastomosis is a final step, but the patient and the doctor understand a successful surgery as a well-constructed anastomosis. So this is a challenge for the doctor. We have to notice and we have to understand that pathological, if we are talking about cancer, pathological or oncological resection shouldn't be affected by our planned anastomosis. So it is a final separated step. Okay, we said that fortunately there is good result with the development of medicine. We have to deal with not only open surgery but also laparoscopic and robotic surgery. Okay, despite the developing of medicine, even in the last 20 years we are still suffering of the most feared complication, leak. Despite the development of different methods, different programs, we are still suffering of leak. And leak, what does leak means? By another words, it means length, hospital stay, loss of function, poor oncological outcome, as we will see when we talk about the complication, and operative mortality, and what's not mentioned here also, the financial reflection of this. So we have still a problem with anastomotic leak. This is a general just introduction to anastomosis. What I didn't mention that a term proximity means bringing two bowel together. Okay, let's move a little bit down again. Before talking about the physiology of wound healing, I would like to mention again that I do not say any information reflecting my own opinion. These are what's written in these literatures. Okay. To understand how the anastomotic wounds heal, actually we have to have a general background of the wound healing in general. There are common principles. For example, if you see in this picture, the phases of wound healing, they are the same in the skin or in the GI system, for example. It starts with inflammation, inflammatory phase, proliferation phase, and maturation phase. And this picture shows you the predominant cell in each phase. But there are some differences. You can see in this picture, this is an important picture, shows you what we call the tensile strength. The tensile strength is the ultimate, the final strength that the bowel reach. And you can see that here that we have a collagen, old collagen, that is destructed due to collagenolisis, which is specific for the bowel. And we have new collagen, are synthesis from fibroblast, we will see. And you can see here that the resultant, the final curve of the tensile strength, we have a drop at about 1 to 2 days. This is the weakest time for the anastomosis and depends only on the sutures that we made. Okay, so we have destruction of collagen, old collagen, and production of new collagen, and the result of this is the lag phase here. Again, to understand what we are going to talk about, we have to understand that we have mucosa, submucosa, muscularis propria, and serosa. Some parts of the bowel does not have the serosa, and we notice that this part have a high risk of leak, high risk of unhealing, not healing of the wound. These are, for example, the esophagus and the rectum. A surgeon called Lampert highlighted the importance of the serosa, and he said that this layer of the bowel is the most important and we have to approximate it. And finally we will see we have Lampert suturing, which depends on a positioning of the serosa, because it's the most important when he studied the highest leak rate or failure of healing in parts that lack of serosa, that have no serosa. But later on, a surgeon called Halsted, he also highlighted the importance of the second layer, the submucosa. And he said this layer have the highest concentration of collagen. And collagen is responsible for the tensile strength of the bowel. And so he said that we should involve in our suturing the submucosa, not only the serosa and submucosa. And he said no need to close the mucosa. For example, we will highlight it again when we talk about the suturing technique. But this is one of the importance. We have serosa, it's important. We have the submucosa, which have the greatest concentration of collagen and should be approximated. And again, during the inflammatory phase in the bowel, let's see what's happened. Similar to the other phases, we have platelets that activate the inflammatory mediator, which finally causes the fibrin plug and close the mucosal defect. Okay. Some surgeon says that no need to close the mucosa, but we will see that it's important to apposition or approximate the mucosa. What happens also in the inflammatory phase? We know that the neutrophil is the predominant cell in the inflammatory phase, and neutrophils are responsible of cleaning the wound of the necrotic tissue. What happens especially in the bowel in the inflammatory phase? The collagenolisis, which we talk about, the destruction of collagen, collagenolisis. The collagenolisis actually it destructs the amino acid, especially proline and lysine, and these are responsible for the collagen synthesis and so the tensile strength. So we have in the inflammatory phase at around day 2, we have the weakest day of the anastomosis or the lag phase, which we talk about. And we said our anastomosis, our healing, our wound depends only on our sutures. Okay? On day 2 to day 4, we have the proliferative phase. In the proliferative phase, we have actually two important things. Actually, in this phase, we have the fibroblast, which is the predominant cell, and this is the main cell that produce collagen. Only in the skin. In the bowel, we have another cells that produce the collagen. These are the smooth muscle, and this is unique for the bowel. We have two sources of the production of collagen, the fibroblast and the smooth muscle. Whatever the in which layer, the muscularis mucosa or muscularis propria, but they produce collagen. And this explain why in the bowel the final tensile strength is reached faster than in the skin, for example. Okay, but we have to understand that the final or how to explain it, the strength before the injury, or what we call it pre-injury tensile strength, as you see here, is never reached. the maximum tensile strength that we reach after the injury is about 80% of the pre-injury. But we call it, this 80%, we call it the final expected strength. So the final expected strength is reached faster in the bowel because the production of collagen from the fibroblast and from the smooth cell. You can see here a very important information that the small bowel reach 100% of expected strength. Expected strength mean not the pre-injury strength, but the strength, the maximum strength, which is about 80%, as we said. At about 1 week, we have the maximum expected strength in the small bowel. But in the colon, no. At 1 week, we have only 50% of the anastomotic strength we reach. Okay. What else? We have finally the remodeling phase. What happens in the remodeling? We know we have collagen maturation and cross-linking. Okay. We talked about the importance of the approximation of the serosal layer and the submucosal layer, the mucosa. About the mucosa, we have to know 3 information. First, actually, its approximation via sutures is not mandatory, as we will see. We have a concept called epithelial repair, or we call it gastrointestinal restitution, and actually it's migration of crypt cell from unwounded epithelium. So there is auto repair called the restitution or epithelial repair simply. It occurs at around day 3, and so mucosal layer is actually positioned at around day 3. What else we have to know? That it contains the goblet cell. These goblet cells secrete mucus, and this mucus is protective for the anastomosis. This is in the mucosa. The third information that we have to know, that some studies found that there are local bacterial changes in the epithelial cell, in the mucosal layer, that can be that can affect the anastomosis. These bacteria can carry a collagenolytic activity, and when we will talk about the leak, we will know the importance of these microbiome changes in leak. Okay, so in general, there are general principles that we have to remember when constructing an anastomosis. First of all, we have to do some parameters that minimize the inflammatory phase and the collagenolysis. These avoiding the tension. The tension on the bowel means the force that get the two bowel apart from each other. So it should be tension free. Minimal necrosis, healthy bowel, airtight closure. How we will get to the airtight closure? Approximating serosa, submucosa, and we will see airtight closure and approximation of the submucosa and the preservation of perfusion. We will talk about the perfusion and how to assess the perfusion. Okay, here are a picture nice, just give you some positive and negative factor that affect the anastomotic healing. We can review it in a different way, patient related, etc. But you can see here positive factor, good nutritional status, even pre-op, hemodynamic stability. You are not going to do anastomosis with a patient who is unstable, healthy bowel end, good perfusion, accurate seromuscular positioning, no distal obstruction, This is a risk factor for fistula. Negative factors: old ages, high dose steroid, anemia, uremia, poor nutritional status, smoking and alcohol. Also, high risk anastomosis. The more distal the anastomosis, the highest risk of non-healing or leak. So, colorectal anastomosis is a risk for or a negative factor for unhealing when we compare it to small bowel, for example. Hematoma formation and fecal contamination, you are not going to construct anastomosis with fecal peritonitis, for example. This is a nice picture. I know that it's not well seen here, but I can summarize it to you. They compare the GI tract wound or the anastomosis from the skin wound. And what is the main differences? Here we have to know that, for example, collagen, we said that collagen in the GI is synthesized from two sources. These are the fibroblast and the smooth muscle, while in the skin it's from fibroblast only. A nice information here that we know that in pediatric age group, the wound on the skin with a little significance, actually it disappears without scar or little scar. But in the GI, if we are going to do anastomosis in pediatric age group, we have significant scarring actually when we compare it to skin. Okay, what else we can, they highlight the important collagenase activity. Collagenase activity is increased throughout the GI tract, while in the skin it is of no significance. Also, the D-penicillamine has no effect on collagen cross-linking, while the D-penicillamine have significant inhibition of the cross-linking in the skin. Okay, these are the GI anastomosis. Let's move to another important step. Fundamental principles of anastomotic construction. We talked about some of them. These are well-perfused segment. Two segments should be vascularized well. We will talk about how to assess perfusion, and also healthy bowel, airtight without any tension, and this leads us to know some mobilization technique. And here they just remember you that anastomosis may be the final step in your surgery, so do not get tired at the most important and interesting parts. Operative planning, and here they light the importance of preoperative planning. Preoperatively, you have to know where does the pathology localized, the extent of your resection. This will reflect positively on your anastomosis, on your well-constructed anastomosis. And of course, when we talk about localization, this leads us to talking about endoscopy and colonoscopy as an important method for localization. And unfortunately, this is not 100% guaranteed method for localization of the pathology. Yes, you can use tattoo for in the pathology during the colonoscopy, but this will help you intraoperatively. What can help you is putting a clip on the pathology, so it can give you an imagination where it exists, where I'm going to do resection, and what kind of anastomosis I'm going to do. And you can see here that this picture for two different patients, both are described on colonoscopy to have a lesion about 60 centimeters from the anal verge, and they put a clip in both patient on the pathological lesion or in the lesion. And you can see the difference in the location. This here is the clip, this is one patient, and here is the clip. Remember, these are described on colonoscopy as 60 centimeter from the inner purge, but two different locations. So clips can help us a little bit. There are some questions that you have to ask yourself before surgery. First, are the two segments of the bowel are mobile, or one of the segments are fixed, for example, rectum or anus? Is there a significant part I'm going to resect? Okay, and what technique I'm going to use for mobilization to reach a tension-free anastomosis? And they talk about what configuration I'm going to do, side to side, end to end. So this is important to know preoperatively. Again, now we are going to talk about mobilization. To understand what does mobilization technique means, it's when we have significant gap between two segments and we want to bring them together. So we have to do, I call them relaxing incision, mobilization technique to bring these two structures. But extremely important that if we are talking about colon surgery, for example, the most important thing that should not affected by anastomosis is the resectional margin. The importance is for, or the priority is for your margin, your oncological resection. You shouldn't go far or less by resection because you want to do certain anastomosis. Okay, and I mentioned it in the beginning of the lecture. What does proximity means? It is bringing two segments together in a tension-free manner. Okay. When we are going to talk about mobilization, we have some technique for small bowel mobilization and for large bowel mobilization. Okay. When I may need to do small bowel mobilization, I have to free the small bowel to reach. For example, if I'm going to do right hemicolectomy, I need the ileum to reach the transverse colon. Or if I'm going to do ileal pouch anal anastomosis, the ileum should reach the anus. So I need some special technique to construct a tension-free anastomosis. Of course, small bowel mobilization is easier and easier to do when we compare it to colon mobilization. So it's easier. And of this technique is what we call it the step ladder technique. To explain what step ladder technique means, again, I'm going to remove, for example, the right colon or the entire colon to bring the ileum to the anus. So what does this technique, which this is step ladder incision or step ladder technique, which is shown to be safe? Actually, you can see here, we want to bring this ileum to the, for example, transverse colon or to the anus. We have first, you can see this line, this dotted black line is the incision where we did. And you can see here that we have to free the mesentery up to the base of the superior mesenteric artery. We free it, we cut, you can see that we cut, this is an incision. We cut the middle colic, the right colic, and the ileocolic. We said, bye-bye, we do not need you anymore because this specimen will goes out. Plus, what we will do, you can see in picture number P, actually, we did a transverse incisions. Actually, a light can help us by transillumination to see that we do not reach the jejunal or ilial branches. These are called relaxing incision, gives us more length for the bowel. Okay, and here this actually an image shows you how we cut the ileocolic artery. The superior mesenteric artery on the left side is patent, where it gives its jejunal and ilial branch, while in the right side actually we cut it, the ileocolic, right colic and middle colic. Plus these incisions, this is called the step ladder technique, which shows to be safe. You can see here, effective and safe for mobilization. Finally, if I want to bring this part, for example, this ileum, which is perfused well, to the anus, I have significant length, I think. Okay, what else we didn't mention in small bowel mobilization? We said that it's important. What can make small bowel mobilization a little bit hard? It is here, I think, obese patient, they will have a large omentum, large specimen. If this part that I want to take is large, short mesentery will make mobilization hard, and intra-abdominal size is high. This will make the mobilization is harder. One of the important step in right hemicolectomy, for example, when I want to do ileocolic anastomosis, is to do hepatic flexure mobilization, and this include gastrocolic ligament resection. So this is the most important technique that we have to know about small bowel mobilization, which is called stepladder technique. Include this dotted black line, resection of the right-sided branches of the SMA, including ileocolic, right colic, middle colic, and relaxing incision through the mesentery. Transillumination, the light can help us, and preserving of the jejunal and ilial branches. Colonic mobilization. Okay, colonic mobilization technique. This is primarily when we are talking about the left side of the colon, when we have pathology in the left side of the colon, in the rectum, anterior resection, etc. So we have to know that the distal segment is usually fixed, so we need some maneuvers to mobilize the proximal segments. Actually, you can see in this picture, this is just a rough review of what mobilization technique we have. They can classify to primary, secondary, and tertiary. I don't want you to remember them by heart, but to understand the concept actually. For example, we have here the primary maneuvers, primary mobilization maneuvers. First of all, we have the separation of the embryonic fusion plan. I know that you know from general surgery background that we have kettle and mattocks maneuvers. This is when kettle when bringing the right colon to the midline, and mattocks when bringing the kettle when bringing the right colon to the midline. It could be used not only for colon surgery, but also for exposure of the retroperitoneal structure, especially in urological surgeries. And mattocks when mattocks bringing the left colon to the midline, and this involve of course separation of the embryonic fusion plan, the kettle line, which presents actually over here the attachment to the retroperitoneal wall actually, or posterior abdominal wall between the ascending and the descending colon. Okay, this is one of the primary procedures. Also, one of the primary procedures, mobilization procedure is splenic flexure mobilization, which it's debatable. Is it mandatory to mobilize the splenic flexure when we are dealing with distal anastomosis, or it's not mandatory? Some uses a rough approximation for attention-free anastomosis. They said that if the bowel can reach past the symphysis pubis, so the anastomosis can be constructed in attention-free manner. This is if we are talking about the bowel, and if we are talking about the small bowel or the colon. If we are talking about the small bowel, they said that there should be a 5 centimeter overlap between the two segments. Again, there is a debate about this information, but we have to understand them. Okay, we said that we have primary maneuvers such as Kettle, Mattox maneuver, bringing the ascending to the midline, and of course this includes hepatic flexure mobilization, and Mattox, the descending to the midline, and splenic flexure mobilization. Secondary maneuvers, these include the vascular pedicles ligation. We will see how the high ligation and low ligation give us extra, after a few seconds, give us extra length for our segment to reach to reach the distal segment with no tension. And tertiary maneuver, if we have no solutions, we can do completion colectomies. Actually, completion colectomy, and bringing the more mobilized small bowel to the anus, for example, or to the rectum, for example, such as ileorectal pouch. And also, as a final resort for our problem, we can just create a stoma. Stoma construction is a tertiary type of mobilization technique with end or colostomy or ileostomy. Okay, about the splenic flexure, there is a little bit information that we have to know. We have different approach. Again, it's debatable. Is it mandatory or not? When we are dealing, for example, with sigmoid tumor, with rectal tumor, is it mandatory or not? This is debatable. But what is not debatable, that we have to know how to do such mobilization. First of all, you can notice this picture. We have different approach: medial to lateral approach, lateral to medial approach. In this picture, they show you how the medial to lateral approach, and the first step is actually to elevate the greater omentum. This is the greater omentum. When you retract it up, you will see the what we call it the gastrocolic ligament, and dissection from medial to lateral until we reach the splenic flexure. Let's see what's written. The greater omentum is reflected superiorly, as we see, and the transverse incision is made along the gastrocolic. Here we have the gastrocolic ligament, releasing the transverse colon and entering the lesser sac. Okay, and what we will see at the most lateral aspect, we will see other retroperitoneal attachments such as the rhinocolic and splenocolic ligaments here, which can be divided. We will see how mobilization technique of the splenic flexure. Do you see this angle? It's a 90 degree. It could be even 180 degree, and unhinging or straightening of this flexure will give us additional size to reach. You can see here, this is the splenic flexure. This is a 180 degree conformation, and ultimately after releasing, you can see it's straight and can reach to the distal part of our GI system. Okay, let's move a little bit. We talked about the splenic flexure. We said it's not that extremely hard. It's not mandatory to see the spleen, by the way, on splenic flexure. Other maneuvers, we said we classify it here as a secondary maneuvers, is the ligation of vascular pedicles. And here we have, you can see in this picture, we have high ligation and low ligation of the inferior mesenteric artery. Did we talk about the superior mesenteric artery? Yes, when we talk about the small bowel mobilization, if you remember, here we talked about the step ladder technique, and we talk about the SMA ligation and preservation, of course not the main pedicle, but the iliocolic branch and the right colic branch and the middle colic branch, and preserving the jejunal and iliac. These are type of what we call it ligation of vascular pedicle as a secondary maneuvers. If we are talking about left-sided or rectum, we are talking about high ligation or low ligation of the inferior mesenteric artery. Let's see together this information. High ligation of the inferior mesenteric artery provide you 10 centimeter additional length, and also inferior mesenteric vein ligation or division give you also length, so the proximal part of the bowel can reach. This is a nice picture that show you the differences between high and low ligation. Let's read it together in order not to miss any information here. High ligation by steps. Steps 1, they do mobilization of the spleen. Actually here, this is the dotted line. 1, it is mobilization of the splenic flexure, descending colon, sigmoid to the rectosigmoid junction. Step 2, it is inferior mesenteric artery division at its origin 1 centimeter distal from the aorta. Over here, this is a step 2. We said that when we do high ligation of the inferior mesenteric artery, we give us some distance from the aorta, as there is a plexus over there, so 1 centimeter from the aorta. This is high ligation. What is under step 3? It is the inferior mesenteric vein division at the base, at the lower part of the pancreas. Over here, it's nearly the inferior border of the transverse colon. This will give us additional length. Step 3, step 4, what we have? Step 4, sigmoidectomy. Okay, the original surgery, sigmoidectomy with appropriate lymphadenectomy, including section of the left colic artery over here. This will get should be cutted to give us additional the left colic artery over here. Okay, this is step 4. Step this is the low ligation on the P. It's the low ligation. In low ligation, what's the difference? The same mobilization. First step is mobilization of the splenic flexure, descending colon, sigmoid to the rectosigmoid junction. Okay. Step 2, it's division of the inferior mesenteric artery and inferior mesenteric vein. Here, you see, this is step 2, where the division occurs at the lower part, no, distal to the origin of the left colic. This is the left colic. As it goes from the inferior mesenteric artery distally a little bit, we do we cut the inferior mesenteric artery and vein, and this will be called the low tie or low ligation of the inferior mesenteric artery. Okay, there is a combined procedure called when we do low tie with left colic resection, and a collateral blood flow through the left colic will happens. So we have high tie, low tie. The remaining steps is similar. The high tie at the origin of the aorta, low tie distal to the origin of the left colic artery here. Okay. What else we have? What we talk about is the unhinging. I hope that the pronouncement is correct. We have this flexure which is designed in a 90 degree, actually approximately 90 degree, or could be, and unhinging means straightening to reach the distal segment. This is unhinging. I don't know, it's unhinging, I don't know. But what we should know, that you can see here the splenic flexure. Actually in this picture they show us, do not pay attention to the information, they show us where our resection or releasing incision should be. It's over here. Okay. You can see here the steps. This is 180 degree conformation. They do a splenic flexure 90 degree conformation, releasing a little bit. They release it more and more. They release it, and finally it's a straight tube. Okay. These maneuvers actually, either the primary kettle mattocks or division of the splenic flexure, releasing the splenic flexure, or secondary the vascular ligation, gives us additional distance so the proximal part can reach. There are special maneuvers. Okay, special mobilization technique. Actually we have two techniques we are going to discuss. Then the need for this technique appears when we are talking about repeated low anterior resection, ultra low resection. So we need the proximal part of the bowel to reach extremely distal, and one of these procedure is what we call it the retroileal anastomosis or ileal mesenteric window. Actually, this is a nice picture. You can see what we do is bringing the right side and even the transverse colon through a window in the mesentery of the small bowel between the superior mesenteric artery and the ileocolic artery. The area between them is a pair area, avascular area. Transillumination can help us to identify this area, and as you can see, we can bring this is maybe the ascending, the transverse colon through this defect, so it can reach past the pubis symphysis, and we can construct our tension-free anastomosis. This defect should be about 4 to 5 centimeter, and this is a picture shows you this is where they create the window, where they bring the colon through the mesenteric defect. I know that it's not extremely clear, but here they mark the pubis symphysis, so the bowel reach the pubis symphysis, so we can reach the distal bowel in a tension-free manner. This is the first procedure. The second procedure that we can use is what we call it the DeLoyer procedure, or colon derotation, right colon derotation. And I think to explain it is better to see this picture. Actually, it's again the same indication when we are talking about distal anastomosis. We can use the right colon as a conduit to do colorectal, coloanal anastomosis, and what we do is actually resection of the small bowel of the mesentery of the colon, and that include also the middle colic and right colic artery up to the ileocolic artery. Blood supply to the right side or the ascending colon is mainly from the ileocolic artery, which we know it is the most constant artery or branch of the SMA. And what we do, as you see, if you can imagine, let's move to this picture. Actually, we do derotation. We rotate it. So this surface, the ventral surface, will ultimately, finally, become a dorsal surface. And the dorsal surface of the mesentery will become the ventral surface. And you can see here that finally that the cecum is located in the upper abdomen, even in the right upper abdomen. This is the ileocolic junction. Okay, and this is the ascending colon. We move it down to reach the distal segment, and finally we can construct anastomosis. The blood supply of this segment depends on the ileocolic artery. We should do appendectomy as the cecum is now located higher up. Okay, what another information about right colon derotation or the lower procedure we didn't say. I hope you imagine it. It's an interesting to when you understand it. Okay, we said that the right colon is chosen as a conduit now. Okay, and the conduit is dependent on the ileocolic artery. Okay. What else? There is here some studies that shows it's safe. It's a safe procedure even regarding the healing. Okay, perfusion is to ensure adequate blood supply at the level of the future proximal and distal limb. And actually this is a clinical assessment. We use clinical parameter that will help us. Does these clinical measurements guarantee 100% perfused or well vascularized segments? The answer is no. But what is suggested that knowing the anatomy of the mesenteric vessel well, identification of each vessel, using good technique for mobilization will usually help in getting a well perfused segment of the bowel. Of this clinical assessment, intra-op, we can use the color. For example, the color of the segment at which we are going to resect and the future proximal and distal limb. Visible bleeding after resection from the mucosa. And what also we use, especially when we are dealing with left colon resection and anastomosis, is we do intentionally transect the marginal artery at the level of the resection and before the resection itself. To see marginal artery again, these are the artery near the bowel itself. And if we see, as you see in this picture, a pulsatile brisk arterial bleeding, this is likely to ensure a well perfused futured proximal and distal segment. These all are clinical intraoperative assessment. As you see in this picture, they cut the marginal artery near the bowel wall, and this is where they are going to cut. If there is a brisk bleeding, so most probably this is a well vascularized to end. Of the newly but not routinely, to be honest, used technique to ensure the vascularity or the perfusion of the bowel is what we call it the endocyanine green fluorescent angiography. And if you watched the lecture about stoma, also it have a application in stomach creation to check a well vascularized and finally a healthy stoma. So endocyanine green is a material that bind to the intravascular protein and perfused to the intravascular compartment to the bowel and other structures. In colorectal surgeries, we can use it to assess the perfusion or the vascularity of the bowel. You can see here, for example, it's the well-perfused segment of the bowel. Of course, here we need special camera to detect these changes. These camera absorb the near-infrared light, and here after they clamp the marginal artery, and after a while you can see a well-perfused segment after cutting the marginal artery and before resection. So we have well-perfused bowel even after resection of the artery or clamping the arteries. Okay, again, is the endocyanine green test mandatory? The answer is no. It's used as an adjunct. One study showed that the endocyanine green test changed the decision of resection based on the clinical assessment in about 80%. So this what we have technique to assess the perfusion to the bowel. Does this technique finally affect the leak or decrease the leak? It's not clear. Okay, anastomotic configuration. And anastomotic configuration is how these two segments will be related to each other. And I know that you know that we have this basic configuration technique. You can see at this picture we have end-to-end A, we have end to side B, or side to side. Actually, this is how we create the end-to-end or side-to-side using staplers, but could be by hand sewn. Just a nice picture. You can see end-to-end anastomosis using a circular stapler. They introduce, actually I think that they introduce the circular stapler through the anus, while here they use the circular stapler with enterotomy, and they close the enterotomy at the end of the creation of the anastomosis. These are end to end, while side to side anastomosis, actually we will discuss these side to side anastomosis. You can see it could be created by different technique. We will see end to side anastomosis. Also here is the end, and this is the side of, mostly this is the ileum and the transverse column. Okay, actually what we want to say that side to side can be isoperistaltic or antiperistaltic. Isoperistaltic, to if you see this picture, isoperistaltic means that the content, the bowel content, is moving in one direction. If we imagine that this is the oral side, this is the anal side, so the content is moving in one direction. This is what we call it isoperistaltic. What's nice to remember about isoperistaltic, that it needs less mobilization of the proximal limb when we are talking about, when we compare it to the antiperistaltic. Sometimes it's the preferred when we want to attach, for example, the ileum to the distal third of the transverse, it's recommended to use isoperistaltic. Okay, this is the antiperistaltic. If you see, now we are talking about side to side. So this is the antiperistaltic. So this is the oral side of the, this is where the oral side of the content, and there is a change in the direction. So it is antiperistaltic configuration. Okay, what else we can add? Small bowel anastomosis, in general we use end to end or side to side. A problem, especially when we perform a right colectomy, facing us is the size discrepancy. Actually, we have a small bowel, the ileum, with shorter than the ascending, transverse, descending. So how to deal with this discrepancy? We have many techniques. One of them is the, as you see in this picture, what we call it the cheetal slit. You can see here we have a bowel, whatever, small bowel, ileum. Here we have a bowel with a larger diameter, and we did an incision on the antimesenteric side. So we widened the lumen or the diameter of the bowel so it can be closed into it. This is what we call it, cheetal slit. Okay. Another way to deal with size discrepancy is what we call it the side-to-side anastomosis. This is one of the advantages of side-to-side anastomosis, that we can deal with discrepancy when we, for example, again, when we want to create anastomosis between an ileum or a relatively small bowel diameter to a large bowel diameter, so we can use size to size. In this picture, they actually show you what we call it Barcelona, Barcelona. I don't know, the pronouncement depends on your country or the language of every country. In some places it's called Barcelona technique. Actually, Barcelona technique is a side to side using a linear stapler. Actually, these are stay sutures on the antimesenteric wall and two intratomies. After we create these two intratomies, this is the lesion over here. Actually, this lesion in the cecum and ascending. So we are going to perform right hemicolectomy, and we use a linear stapler to create a common channel between the ileum and the transverse, let's say, or distal to the lesion segment. So we create a common channel, and after creating the common channel, we remove this piece also using another stapler technique, another stapler. We are not discussing the size now, and this is finally how it looks. This is what we call it Barcelona technique, and you see that this is side to side. Which type, iso or antiperistaltic? This is antiperistaltic. There is a change in the direction. Robotically and minimally invasive surgery, also isoperistaltic. I don't know how to explain for you that this is isoperistaltic technique, but this is a robotic isoperistaltic side to side. Again, the advantage of isoperistaltic that it requires less mobilization. Where is it? This less mobilization of the proximal and distal limb to reach each other when we compare it to isoperistaltic. And so we use it to for example, when we're performing extended right hemicolectomy, we do splenic flexure mobilization, but we use isoperistaltic. Another way to deal with size discrepancy is to use end to side. End to side. Whatever the end, it's closed. the end of the proximal limb, let's suppose, as you see in this picture, whatever the diameter here, it's already closed. And we have the end of the distal limb, it's a wide, as you see, this is, I think, the rectum. And we create an enterotomy to the side of the proximal limb, so we do not fear of discrepancy. So this is another way to deal. It's a stapled end to side, end to side anastomosis. It's another way to deal with size discrepancy. Okay, as I told you, okay, another way that is used, and it's proven that it is associated with lower recurrence, especially in Crohn's disease, and actually it's invented for Crohn's for patients who are suffering from Crohn's disease, is what we call it the Kono-S type. Where is it written? This is Kono-S anastomosis configuration. Simply, what we do is resection of the affected area. Let's say that it is the terminal ileum, the most common site of Crohn's disease. We resect it. We close actually the two ends. The mesentery is not involved. We support the end with hand suturing. We resect it using staplers. Okay, and we remove the pathology. And what we do is creating an incision at the antimesenteric border of the proximal and distal limb. The incision is 7 to 8 centimeter and about half to 1 centimeter distal from the staple line. Okay, we connect them and we did an enterotomies, and then we reconstruct an end-to-end anastomosis. But when we close them, as you see in picture C, they are closed transversely. I think this is called Mikulay's technique. We will discuss it when we open longitudinal and close transverse. Henke-Mikulay's technique. I hope the pronunciation is correct. I think we will discuss it later on, but Kono-S type involve, this is also a structuroplasty technique, Henke-Mikulay's technique. When we open longitudinal, we said it's about 7 centimeter on the proximal distal limb, and we close them transversely. When we actually, you see these sutures, we pull them apart, and this part will be the posterior wall of the anastomosis. It's closed using a single layer hand suturing, and this part will be the anterior layer closed by two layers. One is continuous and other is interrupted. So this is the posterior wall, which is closed by a single layer continuous. This is the final anterior wall, which is closed using a double layer technique. This is the classic description of Kono-S type. So if you are facing a surgeon that used just a single layer for the anterior wall, we are discussing the classic description of Kono-S type. This is how it's look intraoperatively. I don't think that it's clear for you 100%, but you can look to picture number D, where is the final result. Actually, this was created for Crohn's disease, but why not to use it for other pathologies? And also, it's if we are talking about Crohn's disease, it is associated with lower incidence of recurrence of the disease. So this is also another type of how to deal with size discrepancy. Okay, if we are talking about left resection or subtotal resection, subtotal colectomy. So we are reaching the sigmoid. We have no problem to bring the sigmoid, as it is intraperitoneal, extremely mobile, long mesentery, so we can bring it to the right side of the abdomen, so we can create an iliosigmoid anastomosis with no problem. So when we are going to construct subtotal colectomy, so mobilization of the sigmoid and moving it to the right lower quadrant is not that difficult. You can see in this picture, this is the right lower quadrant, and you can see that the sigmoid is reaching with no tension to the right lower quadrant, so we create an iliosigmoid anastomosis. Iliosigmoid anastomosis, the configuration is side to side. This is regarding the small bowel and the small bowel to colon, if we are talking about right hemicolectomy, extended right hemicolectomy. If we are talking about colonic anastomosis, okay, if we are talking about colon to colon, colonic anastomosis, so first, the more distal the anastomosis, the harder to construct. One of the consideration that male pelvis is narrower, so it's harder to deal with. One of the consideration also obese patient is harder to deal with. But colonic anastomosis means that we have lesion in the transverse, for example, splenic flexure and distally. An example, let's just say that we have a splenic flexure lesion. So the classic description of the resection is, and this is a senior recommendation, this is not absolute guideline. So if we have a splenic flexure lesion, so the resection in the mid transverse to the beginning of the sigmoid. And we have a problem here. We are not talking about small bowel to colon anastomosis. We have two limbs that are relatively fixed. So the preferred by the seniors, according to the literatures, that the preferred anastomosis is to create an end-to-end. As you see in this picture, this can be hand sewing or stapler. They use a stapler in this picture. This is a splenic flexure removed, a splenic lesion removed with a splenic flexure. This is mostly the mid or the beginning of the transverse. This is the sigmoid, and they create end-to-end. They preserve, it gives us more distant, good distance to reach in the proximal limb and distal limb, so they reach without tension when we compare to side. So the more the proximal lesion in the colon or in the distal colon, we use end-to-end. When we go more in our anastomosis, we should ask ourselves, are we going to move the rectum or not? The rectum, one of the important functions of the rectum is accumulation of the GI content of the stool. So if we remove it, we will face frequency, urgency, LAR syndrome, low anterior resection syndrome. So we have, by another words, to create a pouch or a segment that work instead of the rectum. In this picture, they show you how we construct end-to-end anastomosis, colonic anastomosis, colonic end-to-end anastomosis, but you see in this picture that the rectum is preserved. This is what we use in anterior resection or sigmoid colectomy. The rectum is in a place, so we can use end-to-end. It's not mandatory to construct a pouch. What does pouch mean? We will see now. But what's different from this picture and this picture, that the circular stapler is here introduced through an enterotomy in the transverse, while here we transverse the circular stapler through the anus, and the anvil actually we fix it in the proximal limb. This is an end-to-end without the need to construct any pouch. As we said, the more distal the anastomosis, the harder we have to think of creating of pouch, a segment that will accommodate for the accumulation of the stool. And here appears the technique which we call it the colonic J pouch. This is the colonic J pouch, and this is one picture. This is the another, which we call it side to end or Baker technique, Baker anastomosis. Actually, here we are going to remove part of the rectum, so we have to create a part of the anastomosis in where the stool should be accumulated so that the patient can accommodate for the urgency and frequency will be less. Here is the G pouch. I think it's clear for you. They remove part of the rectum. They bring part of the proximal colon. It's about 5 to 6 centimeter, and create like a J pouch and an end to side anastomosis created. Okay, here in this picture they show you how we should remove the mesentery when we create a common channel between the proximal and distal limb of the proximal part. And here is the distal part where we remove this is the J pouch. Another technique is we said side to end anastomosis without creating a pouch, just they use side to end anastomosis. They bring this part for accommodation. Actually, if we want to compare this technique from this technique, there is no difference except in that the J pouch technique, colonic J pouch technique, needs longer time. What is not recommended is to construct end to end, such as this, after removing the rectum. It's not recommended. Yes, in some literatures, and this is what's written here, in some literatures says that even after 2 years, if we constructed end-to-end anastomosis, that means we bring coloanal anastomosis, after 2 years an accommodation will happen. But this means that the patient will accommodation regarding what? Regarding frequency, urgency, etc., stool frequency and urgency. This is the Al-Jarrah syndrome. We are going to talk about it separately. But the patient suffering 2 years until accommodation will happen. This is not a reason to construct end-to-end anastomosis low, such as coloanal anastomosis. Okay, actually here they just show you how important to construct a J pouch or side to end anastomosis in the low pelvic anastomosis when we compare it to end. It's recommended to create J pouch or side to end anastomosis regarding every thing. For example, let's see what we do not mention. Okay. For example, here is a study that compare the colonic J pouch compared to straight anastomosis. Straight anastomosis, they mean end-to-end anastomosis. The colonic J pouch anastomosis was associated with fewer reoperation, fewer reoperation, fewer space infection, and fewer ICU stay. So this is an advantage regarding the creation of G pouch in the pelvis. Again, they compare the side to side, the end to side anastomosis to J pouch. It's the time of operation. This will require, the J pouch will require more time. They talk about the Al-Jarrah syndrome. We will talk separately about it, but okay, as we said, side to end anastomosis called Baker type anastomosis. This limb is advised to be 5 to 6 centimeter. What else we didn't mention? Okay, methods of anastomotic construction. We means, is it hand sutured anastomosis using sutures, or using stapled anastomosis, or as we will see using rings, two rings that bring tissue together called compression rings. And from our daily practice, we know that these are not separate technique. We can use them in combination. For example, stapling the bowel to create anastomosis and using sutures as a second layer, so they are not separated. The most important technique is the sutured anastomosis. And it's important because it's like the emergency exit. Sometimes it's difficult to use in certain places the staple. It's not available. It failed. If failed the stapled anastomosis, so we have to do hand sewing. So sutured anastomosis require experience, practice, and if we are talking about anastomosis using sutures in the lower GI, we have to study many parameters. For example, is the suture should be absorbable or non-absorbable? The sutures monofilament should be monofilament or polyfilament? Should the type continuous or interrupted, single layer, double layer, the edges of the wound inverted, everted, normal, positioning, or the tissue purchase. Tissue purchase means what is the level should I penetrate when I'm going through my needle, the serosa only, or full thickness from serosa to muscularis propria to submucosa and to mucosa full thickness. So what's the level of the tissue that I should penetrate, called the tissue purchase? The stitch, how it should be apart from each other, what type of needle should I use. These are all parameters that are discussed in different study. If you want to talk about each parameter apart from the other, so if we are talking about the sutures, let's remember first that, as we said, that finally, when we create an anastomosis, the maximum tensile strength will be reached. So, non-absorbable suture is not recommended. But we know that we have a lag phase or an inflammatory phase at which the anastomosis depends 100% on my sutures. So, it's recommended to use slowly absorbable sutures, such as BDS, polydioxone, for example. If we are talking about should it be monofilament or polyfilament, let's say monofilament and multifilament. This is the multifilament, braided mainly or twisted. So we have to know that we are creating an anastomosis that depends in the lag phase 100% on my sutures. And disadvantage in the monofilament is what we call the memory. The memory means the tendency of the suture to return to its original type. So it will be hard to, it needs more knots, it will be hard to handle, it may return to its shape. So monofilament, regarding due to this property, it is not recommended. Yes, in general it causes less trauma, it causes less inflammation, but it has a memory that for that we prefer braided multifilament sutures. Okay, what else we want to add? Regarding the edges, again, should it be a position like that, or inverting or everting or inverting? Again, let's remember that a surgeon called Lambert noticed that the highest leak in the part of the bowel that have no serosa. And he said that approximation of the serosa with inversion of the other part, as you see here, is the most important, and he called it Lambert stitch or Lambert sutures. Okay? A positioning, when we are talking here, this is when we use a stapler. Stapler do not invert or evert the edges. Finally, to give you the conclusion, it's best to invert the edges. But let's remember that surgery developed and we noticed that the submucosa contains the highest level of collagen, and so on. Another surgeon called Halsted says no, positioning only the serosa is not enough and I need to reach the submucosa, and this is what we call Halsted stitch. Halsted stitch, reaching from the serosa to the submucosa and inverting the mucosa inside. To see a picture, it will be clear. This is Lambert stretch. This is approximation only the serosa, as you see here in this picture, and inverting the other part of bowel wall. Sometimes they call it near, far, near, near, far. This is Lambert. There are many modifications. There are modifications, Zerny modification, in which we use another internal stitch as a first step, and as a second step we use the Lambert stitch called double layer anastomosis. Okay, can we depend on the size? For example, can I say please do 3 to 5 millimeter depth for your suturing? Roughly yes, but we know that the thickness of bowel differs according to site, according if there is pathology or not, inflammation or not. But roughly we say we need to go deep 3 to 5 centimeter and apart from each other 3 to 5 millimeter, 3 to 5 millimeter. If it is a normal lower GI bowel segment, 3 to 5 millimeter using, for example, simple continuous, we will reach the upper part of the mucosa. We will reach just to the mucosa. We will not penetrate the mucosa itself. And this is what we call the canal stitch. Canal stitch is a horizontal mattress that is full thickness. It reaches the just below the mucosa a little bit. This is again Lambert. This is Halsted when he reached the submucosa, which have the highest level of collagen. So finally, what's recommended? We will see. Okay, we said roughly we can see that suture height should be 3 to 5 millimeter and 3 to 5 millimeter apart from each other. Again, what's the recommended needle shape? Cutting? Of course no. Round, non-cutting needle. This is the simple stitch. Simples means using 3 to 5 millimeter height, we will reach serosa, submucosa, and a small part of the mucosa only. Okay. Before talking about continuous or interrupted, this is a modification of Lambert in which they use an inner full thickness stitch and approximating the mucosa. Actually, this is hard to perform because this will be the first layer you will perform, and this will be the second layer. If we take a look here, these are two segments. This is double layer using Lambert. The outer layer you can see here. This is the posterior wall. The outer layer using a Lambert stitch, only approximating the serosa. The second layer of the posterior wall is over and over continuous. Okay, the inner layer of the anterior wall is using what we said, the canal suture, a vertical mattress nearly full thickness. Okay, and the outer layer Lambert stitch. Okay, this is double layer. These are the same. These are the same two pictures you can see here. Before even opening doing an enterotomy, he approximated the serosa, then a second layer here in the posterior wall, and here he performed the anterior wall using Lampert's stitch. Okay, again, what's recommended regarding this technique, we will see. If we want to study, is it preferred to do continuous or interrupted, you will see, or you will notice in many literatures, they recommend interrupted suture in lower GI, in the lower GI anastomosis, but actually the study shows that there are no difference in the outcome between the two techniques. But of course, the continuous is faster, not only faster, but also, okay, here they say that continuous, less time, faster, suture is more watertight. This is not 100%, okay, better hemostasis. And one disadvantage is that continuous sutures line is based on a single stitch. If one stitch disrupted, all suture line will be disrupted, and this is interrupted. I see in many literatures you will notice that they recommend interrupted sutures. This says that it's better for oxygenation and vascularity. What's clear? Okay, what's clear is the single layer or double layer anastomosis. It's actually, we noticed that the single layer is preferred when we compare it to double layer anastomosis. As we said here, this is a double layer anastomosis, this is a double layer anastomosis. Single layer is preferred, and you can see here, for example, single layer continuous versus two layer interrupted. The single layer anastomosis is better regarding, let's see here an important information about the single and double layer anastomosis. The two layer anastomosis require greater operative time. Not only that, another thing, two layer anastomosis result in stenosis. What else? Greater degree of ischemia and necrosis. So if the decision between single and double layer, the single layer is recommended, but actually, as we said, it's surgeon preference. This is a nice picture, actually shows you how when we take a zoom out and we look to a lecture that is discussing the anastomosis in general, they give you different indication. These are not absolute indication. These are not things to remember by heart. For example, here in this lecture, I find it on the internet, they advise for large bowel or small bowel anastomosis, a single layer. Okay, no debate, that single layer is better. Interrupted, extramucosal. Extramucosals, we say Lampert is extramucosal, Halsted is extramucosal anastomosis. While in the biliary surgery, they advise single layer, interrupted, full thickness. And in gastric or gastrojejunostomy, they recommend single layer, full thickness, continuous. You know, this is what I mean when I mention that we are now concentrating more on lower GI anastomosis. We said the preferable option is to do single layer anastomosis. If we are talking about interrupted or continuous, no difference here. You can see that suture anastomosis can be performed using interrupted or continuous. Continuous, yes, it's faster, but no difference in the outcome when we compare each technique to other. One of the thing I want to show you here, a slide over here, they recommend interrupted. Why? Interrupted suture preferred over continuous because pre-anastomotic oxygen tension lower with continuous. They mean that when we use continuous suturing, more strangulation will happen. Narrowing of the lumen occur with continuous sutures. So we will summarize what we say. Okay, we discussed this type of, hand sewen. Sometimes it's mandatory to use hand sewen, especially when we deal with extremely lower GI anastomosis, when we do mucosectomy or intersphincteric resection for low rectal cancer. Hand sewen anastomosis is what we use. Let's summarize what we say. I know we just reviewed the information, we will summarize it. We use, first of all, slowly absorbable sutures, braided sutures, slowly absorbable when we compare it to non-absorbable or rapid absorbable. What we say, braided multifilament when we compare it to monofilament. It's recommended to use zero submucosal stitch, such as in Halsted. It's not recommended to reach the mucosa. This is regarding the depth. It's recommended to invert if we are talking about inversion and eversion. No difference in regarding interrupted or continuous. But many literatures prefer interrupted. If we are talking about single layer compared to two layer, so single layer is recommended. What else? Bite thickness 3 to 5 millimeter, apart 3 to 5 millimeter, round needle. These are the information. I know that you are waiting a classic one information to remember, but unfortunately science is not like that, and I know that you know that. So these are the general concept when we are talking about sutured anastomosis. What else we can see? This is actually hand sewen anastomosis, and they recommend single layer continuous over two layer. Okay, single versus two layer. Single layer, reduced surgery time, lower cost, less chance of narrowing of the lumen, less chance of compromising blood supply. Okay, these are different technique. One of them you can see here, telescoping. These are old-fashioned telescoping of one segment into another, called Joppert suture. This is the Lampert. This is Lampert also. This is Lampert using two layer. This is modified by Krenzi and Kocher. They are the same actually. Lampert modified by Joppert. Okay, Joppert means they take full thickness, entire thickness. We said Lampert is only the serosa. Okay, we finished talking about sutured anastomosis. We now move to stapled anastomosis. Okay, stapled anastomosis, and this in this picture you can see what do we mean by stapler. It's an instrumental anastomosis. Actually, a problem can face us when we want to discuss scientifically about stapled anastomosis. The problem is many information depends on the model and the brand itself. So it may be an manufacturing industrial issue rather than purely scientific issue. First, it was described by a Hungarian surgeon called Halt in the 1917, and we have in the modern surgery multiple shapes of the stapler. You can see actually any stapler can be cutting or non-cutting, just stapling, closing the lumen, or closing and cutting in between. So this you can see will create a linear anastomosis. Here we have the curved, okay, cutting. Here they mentioned that it's cutting stapler. It could be non-cutting. This is the curved, or sometime we call it the contour. It could be straight, by the way. It could be straight linear. This is a straight linear stapler. This is the curved anastomosis, and they call it the contour. It's usually used in open surgery in the low anastomosis, in the rectal surgeries. Okay, the stapler. Okay, we said we have the linear, curved or straight, cutting, non-cutting. We have here the circular stapler. It could be used in the low rectal anastomosis, or even for end-to-end lower anastomosis, or side-to-side, end-to-end in the upper GI. It doesn't matter where to use it, but we will have a picture better than this. Here is the anvil, here is the introducer, and they connected together. We will see a picture clearer than that. And there are some are designed only for some stapler are designed for laparoscopic stapling. As you see in this picture, we have the endoscopic linear cutter. It's designed to travel through the port and the abdominal wall. This is the powered articulating. Articulating, that means that there is a joint here. It goes up or down, depend on the brands. The degree depends on the brand. So articulating. Powered means that there is a battery and the firing is automatized previously. Okay, the staple itself, this one, as we will see, is made of titanium, and titanium causes less tissue reaction. I found in the internet that this is that the staple is made of titanium and some amount of nickel, so we have to figure out if the patient have a nickel allergy. Here is after firing. Here is the final shape of the staple, and you can see the anatomy here, that we have the leg and the crown of the stapler, or I call it the clip. So these are the leg, this is the crown, and after firing it create a P shape, as you see here. You can see that we have different P shape that are acceptable. Up to here, from 1 to 12, these are all acceptable shape of staple. But from here to here, these are not acceptable shape. Misfiring or technical issues can happen, so it's not acceptable. These are the how can P form staple. And 3D. 3D means that when we close the legs to the crown, they shouldn't in 3D they goes lateral more. So this is 3D. They said that it gives advantage in that it covers more tissue size. So okay, this is the 3D. I hope you understand it. It's like this. Okay, these show you how good staple formation P shape up to pad. The Again, this is the leg crown after closure, after firing, after creating the anastomosis, the a row of staples created, a straight row of staples created, and actually you can see here, for example, this type of anastomosis create 3 rows on one side and 2 rows on the other side, and this can be used so that the patient have more rows, more clips than the specimen that we will get it out. This may ensure sealing of the or reduce the risk of leak. Sorry. The size over here, if you see 55 millimeter, 75 millimeter, 100 millimeter, this depends on the length of the this is what we call the cartilage and the anvil, the length of the anastomosis we are going to create. Actually, you can see here, for example, if we take this is about 7.5 centimeter, and it creates 2 rows on each side of the cutting edges. Okay. Here, for example, in some staplers, it creates, if we imagine that here we have a line that separates the 2 segments, it creates 3 rows in one side and 2 rows in the other side. Okay. Again, let's move a little bit down. I want to discuss, this is the anatomy again, and if you hear before, we have different color of the cartilage. This is the cartilage. Where is the cartilage? Well, this is what we mean by the cartilage. We have different color. Actually, I think it's over here. Sorry for that, but this is the cartilage. So depends on the cartilage, the size, and you can see the size of the clip differs. For example, in the gray, here we have in the gray, we have the open and the closed height. The open height is 2 millimeter, while after the closure it's 0.7 millimeter, and it varies: white, orange, purple, black. There are no definite indication for each part because the thickness of the bowel is not constant. This may be altered by edema, this may be altered by pathology, but generally speaking, we use green one. You can see that green one, the closed staple height after we close it, it is 2 millimeter, which is relatively large. So we use it for the pylorus, for example, for lower GI, colonic rectum, we uses green stapler line. And here you can see the recommendation, the rough recommendation. For example, gray, it is for the mesentery, so I think it's small. The open height is 2 millimeter, 0.5 the closed height. As you see, this is the open height, and this is the closed height after closure of the staple. So blue is the standard. We can use blue for small bowel, actually, green for large bowel, but these are rough approximation. And even if you choose the size, you can accommodate by more compression, as we will discuss now. Okay, we said gray for mesentery, white for vascular, blue is the standard, gold for thick, and green for thick. And you can see the sizes, how it differs from open and closed height. Okay, what else? They also, the sizes. This is about this is regarding the linear. This is also regarding the circular stapler. The circular stapler, we have two issues: the diameter and the clip itself. For example, here we have a diameter of 31 millimeter. Here we have a 31 millimeter diameter, and the open height of the stapler is 4.8, which is relatively thick. It's used in the lower rectum. So we have to use the appropriate, by the way, diameter. For example, we cannot use a small diameter in the lower GI, so a stenosis can occur. Okay, so this is regarding the stapler, the circular stapler. I just mentioned this picture of, commonly we use circular stapler for low pelvic end-to-end or side-to-end anastomosis. Okay, we discussed this issue. Okay, compression. They focus on how compression is important before firing. After you use your staplers, you compress the tissue between the staplers, and so the fluid in the tissues, whatever, intracellular or extracellular, will get out of the staple line so that the staple can be formed well. And there are different type of compression. Depends on the type of the stapler. Circular stapler, linear stapler. We know that the stapler we use for open surgery, we actually compress the tissue between our two limbs of the stapler. But in endoscopic, there are different technique called the cantilever technique, I think, cantilever mechanism for compression. It doesn't matter. We have to understand that compression before firing is extremely important. What is the recommended time for compression? Above 15 seconds up to, above 15 seconds up to 1 minute even. What else we can say about compression? One of the problem that can face us, it's not this, but we will discuss this actually after firing. Some staple will not go through, especially the weakest point. While creating a stapler anastomosis, the weakest point is the farthest, the most farther. The anastomosis from the staple line is the weakest. So we have at least visually to examine the stapler if there is any clip that are missed or fallen out of the stapler line, so we have to remove them. This picture, actually I found it in the internet. They show you how second line hand sewing sutures farther from the staple can cause a tear in the staple line, so it's not recommended. Okay, in my usual practice, this is extremely depends on the surgeon. Some surgeons will not permit stapler to be the single layer technique. They use hand sewing, and they even go past that. This is surgeon preference, and you have to respect that actually. What else we can? This is the linear cutter stapler. You can see that we have different size here. It's usually used, as we said, for rectal transection in open surgery. I'm trying to pick any missed information I didn't mention. They here just discuss how important the compression is. Okay, these are different design. As we said, compression in laparoscopic surgery is different a little bit. You can see a video on YouTube, and The problem that these are different and depends on each brand and each manufacturer. So these are the articulating endoscopic stapler. This is a powered called the Signia stapler, also articulating. They cause compression by different mechanism, and what is discussed here actually, it's, I don't want to disturb you, how compression could be just with single fire, or we have to do multiple fire while compression. It's I think when you use a stapler, you have to ask what stapler I have in my hospital, and I have to study or to be familiar with this type of stapler before using it in the theater. Okay, one of the important things when using staplers, especially circular staplers, is to examine the donuts, the two sides of the specimen that is taken out. So complete donut means that the stapler line is usually healthy. And also it's recommended, if we are using circular stapler in lower GI anastomosis, to perform to perform the air test. This is how we can perform it. Actually, this is water, and we close the proximal limb by our hand, or if we use laparoscopic technique, instrumentally we close it and we inflate. We immerse the field with water and inflation, and any leak will cause pupils. Or endoscopic, we can use endoscopy to examine the staple line. Finally, let's read the summary together. In summary, waiting longer than 15 seconds is recommended, as I said, up to 1 minute. Okay, what else we can add? Okay, we discussed the most important thing. I hope you understand. Again, to summarize, if we said we have 100 millimeter stapler, green 1. So green is recommended for thick tissue because we have the highest open and closed height, as you see, and 100 means the length of the anvil and the stapler line. This one. Okay. Again, to be honest, after reviewing many literatures, it's extremely how to say, it extremely depends on the brand itself. And here my advice for myself and for you, before proceeding for using stapler, ask what stapler I have in my hospital and be familiar with it, because it differs and depends on what brand we use. Another method of anastomosis construction is the compression ring anastomosis. And compression ring, as you see in this picture, there are two rings that compress the tissue between this ring and causes a sutureless rejoining of the two bowel. It's not widely used, especially in Europe and America, but you can see this ring could be metallic or biodegradable, so absorbable. They eventually here between the two rings, and ischemia and necrosis will happen, and it will fall down if it is non-absorbable. We are talking about. Of course, there are studies that compare the sutureless or the ring anastomosis, the compression of tissue, and other hand sewn or stapled anastomosis, and actually it's not bad. You can see there are no significant difference in anastomosis leak structure or mortality. There was a shorter time to return of the bowel function in the compression ring. No difference in terms of hospital stay. No significant difference was seen in the post-operative morbidity. Okay, of course, here we have foreign body, so a slight higher rate of bowel obstruction. Also, not only that, the inflammation was less actually. You can see here that diminished number of inflammatory cells as well as less scar formation compared to stapled anastomosis. Fewer adhesion also noted. I don't know, to be honest, why it's not extremely popular method of anastomotic construction. So, and finally, they try in this literature and even in other literatures to do a comparison between the hand sewn and stapler anastomosis. But to give you the conclusion, what's clear that hand sewn is longer than sutured anastomosis. The other parameters actually is controversial with no significant statistical differences actually. Okay, actually they highlight on the ileocolic anastomosis and how in many studies they found that using hand sewn anastomosis is associated with higher leak when we compare it to stapled anastomosis. You can see here regarding the ileocolic anastomosis, okay, the leak rate was 2.5 in stapled anastomosis and higher in hand sewn anastomosis, with no difference in the other parameters like the structure, bleeding, reoperation, etc. That's all. No, as I said, no statistical differences between the two, except which is logic that the hand sewn is longer. This is the end. You can see here the controversies, type of sutures, single suture versus double suture, continuous versus interrupted, hand sewn versus stapled, inverting versus. Okay, inverting, I can say that inverting is better than inverting. NG tube decompression, if you watch the lecture of enhanced recovery, it's recommended if only there is obstruction. Abdominal drain also not recommended in enhanced recovery after surgery. Okay, this is the end of the first part of our lecture. We move to the second part. Okay, the second part of this lecture, we are going to discuss anastomotic complication, and of these anastomotic complication, we have leak, the most concerning problem to deal with, fistula formation, bleeding, ileus, surgical site infection, intra-abdominal abscesses. These are early leak and late, early complication and late complications such as anastomotic structure or obstruction. Okay, if we are going to talk about leak, so leak also can be classified to early and late, or early, intermediate and late, early before day 3 and late after day 8, and some literature says that early usually due to technical error, while late and require immediate intervention. This is especially or more correct if we are talking about upper GI anastomosis, but And some literature says that also late leak is due to infection of the stapler line. So this is okay. So early before day 3 and late after day 8, between them we call it intermediate. The problem that even with the usage of evidence-based preoperative guideline, appliance will to the or adherence will to the ERAS protocol, and if patient with no risk factor with ideal surgery, leak can happen. So, and leak finally will reflect on the cost needed financially, on the additional diagnostic tests required, on the hospital length of stay, morbidity, mortality of the patient, the need for readmission. So, okay. Leak, if we are talking about the risk factor of the leak, so site is the most common risk factor. The risk of leak is lower for small bowel and ileocolic anastomosis, and higher in ileorectal and distal colorectal anastomosis. We say rectal anastomosis to rectum, colorectal, ileorectal is high. This is a nice picture, says that small bowel anastomosis, low risk, esophageal colorectal, high risk. Colorectal, word rectal means higher than ileocolic or colocolic anastomosis. The more distal the anastomosis, the more risk of leak. Okay. There are certain, or the risk factor can be classified as a patient-related risk factor, such as DM, hyperglycemia, and high HbA1c, male sex with a narrow pelvis, higher body mass index, obesity, tobacco, smoker, inflammatory bowel disease, immunosuppressive drug, radiation, and malnutrition, which is laboratory reflected as hypoalbuminemia, active infection. These are patient-related risk factor. One chemotherapeutic agent, bevacizumab, is a risk factor of leak and should be stopped pre and post-operatively 6 weeks before and about 1 month after the surgery. This is a nice picture, says that anastomosis less than 10 centimeter from the anal margin have higher risk of leak when we compare it to anastomosis more than 10 centimeter from the anal margin. So the more distal the anastomosis, the higher the risk. Also, it highlights that high ligation of inferior mesenteric artery at the pedicle of the aorta increases the risk of dehiscence, anastomotic dehiscence or leak. Male gender, as we said, the male pelvis is narrower and we have a technical difficulty. Intraoperative risk factor of these, inability to achieve attention-free anastomosis, poor blood supply, okay, blood loss and blood transfusion, prolonged surgery, intraoperative contamination, usage of multiple stapler firing across the rectum. Okay. And the multiple usage of stapler firing across the rectum, usually this will be in the laparoscopic and robotic surgery. Okay. The operating surgeon, unfortunately, is a risk factor, but we do not know what is the characteristic of the surgeon that causes the leak. So, operating surgeon is a potential risk factor, although little is known about which surgeon characteristic. Is he fast while constructing anastomosis, or he uses certain techniques? We don't know. Okay. Another parameters is the usage of drain in the abdomen, whatever, open, close suction, drain. It's not clear that does it increase, decrease, or natural. It's not clear if it is a risk factor for leak. Another unclear parameter is the usage of fecal diversion, especially when we are talking about protective fecal diversion. It's not clear whether it's a risk for leak or not, or help in controlling the leak. Which is known well to decrease the risk of leak is the usage of mechanical bowel preparation plus oral antibiotic. I hope that you can forget "or" here. Mechanical bowel preparation plus oral antibiotic. If you remember from the lecture of ERAS, these are associated with reduced risk of anastomotic leak, and this highlights the importance of gut microbiome. Some bacteria can cause or can increase the collagenolisis, and these changes, these local changes, can increase the risk of leak. Of these bacteria is the Enterococcus faecalis, which is proven that it degrade the collagen and activate the tissue matrix metalloproteinase. Not only Enterococcus faecalis, but there are Pseudomonas. This may explain why oral antibiotic can reduce the risk of leak. Pseudomonas aeruginosa also associated with increased collagenase activity and finally with leak. There are certain bacteria that are protective regarding the leak. This is a nice picture. I found it in the internet. You can see here that Enterococcus faecalis, bacillus, they degrade collagen and increase the leak, while some bacteria can be beneficial for anastomosis, such as Bacteroides fragilis. Okay, forget about this picture. This is not now. Let's move how we can diagnose leak. Okay, when we talk about diagnosis of lower GI leak, it's not easy like diagnosis of upper GI leak. Usually when we compare it together, upper GI leak presented earlier relatively when we compare it to our lower GI. The lower GI have vague sign and present later, as you see in this picture. Gastroduodenal leak usually within the first 24 hours, especially when we are talking about bariatric surgery. I remember from my board preparation that the first sign in upper GI leak, especially in bariatric and bypass surgeries, was tachypnea, early leak. This is immediately after surgery and require return to the theater. Lower GI is a different concept actually. You can see here small bowel and colon. Actually, the leak present 5 to 7 days, maybe earlier as we will see later, and or earlier, but later usually, even up to month. The lower is more vague. Here is a Dulc score. I hope you remember only the name. There are 13 parameters. Of them are the vital sign, temperature, pulse, respiratory rate, oligouria, etc. We have clinical signs such as abdominal pain and ileus, and laboratory sign such as creatinine and urea, white BC, and enteral nutrition and parenteral nutrition is within the Dulc score. Modified Dulc score uses clinical sign, any deterioration in the clinical condition, respiratory rates, abdominal pain, and CRP. More than 1 is suspicious for leak. And the classic Dulc score, more than 4 is suspicious for leak. As you see here, we have a concept early and late leak. Late leak, which is usually the manifestation of lower GI anastomosis, or how leak in the lower GI present. It's usually vague abdominal pain, prolonged ileus, abscesses, suspicious drain output. And here is a classification in the International Rectal Cancer Study Group classifies leak, and this classification guides the management. Grade A, it is only radiological sign with no clinical sign and no intervention. Grade B, when we need only therapeutic intervention. And grade C, when there is clinical sign of peritonitis, rigidity, so surgical intervention. Okay, we know well that CT scan with retrograde enema is the highest sensitivity and specificity for leak. Okay, and in the immediate post-operative period, actually CT will not help, because up to 5 days no specific radiological finding more than operative changes. So in the immediate post-operative period, if we have early leak, which is rare in the lower GI, we can find fever, leukocytosis, pain, suspicious drain content, prolonged ileus. Okay, you can see even here they say that CT scan within 4 day of the operation have no specific changes. After 5 days, we start to talk about the rim enhancement of the fluid and the creation of an abscesses. Of the CT features that we can find, free air. Free air can present immediately after surgery. This is why CT is not helpful immediately after surgery. Extravasation of the oral or rectal contrast, and free air. What also we have abscesses. These can be picked during the CT. Okay, what else we have and want to add? Okay, of course, leak, we said it's late, it's 5 to 7 days, means within the first week, but that doesn't mean it may not present later. It could be presented over a month after surgery, and this will present with vague abdominal pain. You can see, especially patients who are going rectal cancer surgery, anterior resection, anastomotic leak become clinically evident over a month after the surgery. You can see again what we said, immediate post-operative period, non-specific symptoms such as fever, peritonitis, sepsis. You can see here in this picture that we have, this is the suture line using, I think, staplers, anastomosis, and round stapler. And you can see here that we have fluid over here and inflammation. Circular stapler. This is what I'm trying to remember. Okay, we have here free fluid and here a gas locule. Here we have also gas. This is not intraluminal. And we have gas over here. We have inflammation. We have gases here. This is actually a fistula, complication of a fistula. Okay, as we said, late leak tend to present vague as a pelvic pain or failure to thrive. Okay, what can help us in diagnosis again of lower GI leak? They said that C-reactive protein and procalcitonin helps us, and they have the significance of them that they have a high negative predictive value. So negative predictive value. So if they are less than certain value, we can ensure that our patient will not suffer from leak. I don't want you to remember the numbers, but actually the CRP should be measured on dynamically on different day, on day 3, day 4, and day 5. And if it is less than certain values, we have negative predictive value that reach 97. And also the same for procalcitonin, that should be measured on different days, and we have a high negative predictive value. Another way that is not routinely used, I'm sure that it's not routinely used, is what we call the anastomotic biomarkers. These are nice. You can see they do resection and anastomosis, and we have a sensor. They implanted a sensor intraoperatively. These are sensors. These actually detect the O2 saturation, the O2, the pH, and the C-reactive protein, and tell us if there is a suspicious for leak. A nice way. So this is how we diagnose leak. Let's move to the management. Okay, management of anastomotic leaks depends on many factors. Of this factor is the patient-related factors, such as is the patient stable or not. If he is not stable, fecal peritonitis, etc., this is a clear indication to proceed for surgery, reduce again for surgery. Another factor that play a role in the management is the size and time. We know that regarding the time, that usually lower GI anastomosis present late compared to upper, and GI anastomosis, and late leak means that we have adhesion, we have obliterative adhesion, and a question appears about the accessibility to the anastomosis and the leak itself. Is it accessible or not? We said this is about the time, the size. The more distal the anastomotic leak, the higher chance to bring a permanent stoma. the more distal the anastomosis, the harder to deal with. Another factor that plays role is it contained or not contained leak. We said that sometimes we have no option if it is not accessible except then washing the abdomen, putting a drain, and bringing a proximal stoma, as you see. Proximal stoma to divert the stool. This is just a picture to imagine what does proximal diversion mean. Okay, we talked about that the more distal the anastomosis is, the more harder to deal with, and also the more proximal easier to deal with. So if we are talking about small bowel or ileocolic anastomosis, so resection and reanastomosis is easier with washing, of course, the abdomen. Of course, here we should ask ourselves, is the bowel is viable? Is the patient is stable? Are the two segments that we will reconnect them again mobile without any tension? These should be asked. For colorectal anastomosis, distal anastomosis, here again a problem about the accessibility appear, and sometime just bringing an end colostomy is a choice. If we have distal anastomosis, this say colorectal anastomosis, and we have leak, so bringing the proximal part as end colostomy, the distal part or the rectum, we have a problem in the dehiscence, so we have to oversee when the distal part and or the rectum, putting a drain near the rectal stump and putting a drain through the rectum to prevent the dehiscence. Okay, if the index surgery or we started laparoscopically, we can redo surgery due to leak laparoscopically, but a chance to convert to open is high, but not contraindicated to proceed or to deal with leak laparoscopically. Okay. If we said that contained or not contained, if we are talking about contained leak that is lesser than 3 centimeter or abscess less than 3 centimeter, this can be treated non-operatively by antibiotic, whereas larger abscesses may require percutaneous drainage, okay, with antibiotic. Sometimes it's up to the surgeon if he wants to use combined technique, percutaneous drainage plus fecal diversion. Okay, if we are talking about colorectal and coloanal anastomosis that are not contained but accessible transanally, so we can place the drain through the rectum by the surgeon or by the radiologist. As you see in this picture, we have distal leak and we place the drain through the rectum and through the dehiscence to the leak. Later we will reoperate the patient, but because we have leak definitely, but it gives us time to do surgery. Surgery can be done without permanent colostomy or permanent stoma. We can do surgery after 3 months with resection and anastomosis. Okay. This is how we place the drain if we have distal leak. Again, surgically by surgeon or by radiologist. Okay, sometime we have no choice except of doing completion protectomy and permanent end colostomy. Okay. If the anastomosis is distal, so the approach can be transanally, and if the anastomosis, if the anastomotic leak is distal, we can use some flap technique. For example, the endorectal advancement flap, the dermal advancement flap, primary suturing through the anus. I know that these, for example, the endorectal advancement flap is classically described for fistula, but it can be used for anastomotic leak. We have actually two technique that we can approach the leak through the anus. One of them, as you can see here, it's similar to the laparoscopic, but transanally. This is to the surgeon side, and this is how it's look. This is called the transanal minimally invasive surgery. We can treat leak by this technique if it is distal. And we have also the microscopic transanal endoscopic microsurgery. As you see in this picture, the surgeon is looking through the microscope, so it's called TAMIS and TEMS. Okay, what else we have? Again, one of the non-complication of the leak is creating a what we call it presacral sinus. This is a presacral sinus. Actually, it presents as a late pelvic pain with sexual fecal dysfunction, and the treatment of it, we can put a drain inside, or we can do septotomy. You see the septum between the sinus and the lumen. We can remove it and create a common channel between them. This is how the sinus looks like. Okay, this is also how presacral sinus as a complication of low anastomotic leak looks like. Okay, there are newer technique that can be used to treat leak, especially in a stable patient, and these include, as you see here, endoscopic vacuum sponge placement. It could be placed by surgeon or by the radiologist. They place the sponge. So, and again, this gives us time just to repair the defect later on. Okay. Another technique is intraluminal covered stent. As you see here, we have a stent that goes across the leak. Here we have a stent, clear radiologically, and the last technique is the over the scope clip. As you see here, they close the defect using a clip. Outcome after anastomotic leak. Okay, we said that the more distal the anastomotic leak, the higher risk for permanent stoma. We have a big problem that rectal leak or rectal anastomotic leak, especially if we are creating the surgery for cancer, it's associated with decreased the overall 5-year survival. So anastomotic leak in the rectum is associated with decreased the overall 5-year survival. Okay, what else we can say? Also, leak, as you see here, the worst oncological outcome have traditionally been attributed, it delay the adjuvant chemotherapy. If we have leak and the patient needs after our surgery to go for chemotherapy, so delay the in adjuvant chemotherapy is a big problem. Also, what we have here, I want just to show you for the third time, I repeat it, the risk of permanent stoma after anastomotic leak depend on the location. The more distal the anastomotic leak, the higher the permanent stoma. Again, we have a problem that the functional outcome and the quality of life after anastomotic leak. This means, let me show you where is it. Poor incontinence, increased bad use, more frequent bowel. These are associated with leak. Not only that, but sexual and urinary function are affected negatively by leak. So, okay, this is what we know about leak. Let's move a little bit to the anastomotic fistula. Okay, anastomotic fistula is one of the complications of the anastomosis, and it can be due to leak if it is late fistula or if it's early fistula due to technical error. As you see here, we have a fistula between the anterior wall of the rectum and the posterior wall of the vagina, and the hysterectomy increased the risk actually of creating similar fistula. The fistula can be between the urethra. Okay, actually, operation with similar to deal with similar fistulas usually require permanent colostomy because we have a diseased rectum already. But if the continuity is extremely required and the patient do not want a permanent stoma, we can proceed for coloanal anastomosis. Okay, if we are talking about fistula that is up a little bit, so we are talking about intercutaneous fistula, colocutaneous fistula, and we know the classification of this fistula: high output, low output, high output, and persistently low output fistula require surgery, but please choose appropriate time. We may start with medical treatment to avoid the hostile abdomen. The rectal also fistula can open to the buttocks. So this is one of the location. Another odd location is the epidural space. So can causes epidural abscesses, and this is a rare location. Okay, blind loop syndrome, one of the complications of the anastomosis. It is, if we are talking again about lower GI, because most of them I was familiar with them when I studied the upper GI anastomosis or the upper GI surgeries. Blind loop syndrome actually appears when we use side-to-side antiperistaltic anastomosis. To understand the concept, what happens is that we created anastomosis and it gets dilated, and there is a stasis of the bowel content in this dilatation. This is what we call it blind loop syndrome or stagnant loop syndrome. In the lower GI, if it is happened, so the manifestation is extremely vague, not like the upper GI. In the lower GI, we have small intestinal bacterial overgrowth, pseudo-obstruction, volvulus, ulcer, bleeding. These are non-specific manifestation for the blind loop syndrome. As you see here, we have dilatation. This is proximal distal. We have dilatation due to side-to-side anastomosis. The symptoms, as I said, these are vague and require sometime CT, capsule endoscopy, push endoscopy to diagnose. The symptoms listed over here, these are related to upper GI when we, for example, construct pylorus 2. For example, we have vitamin B12 deficiency, folate deficiency, iron deficiency. The bacteria uses these, the bacteria that stasis resident in the dilatation uses this instrument. But in the lower GI, the symptoms are more vague. How to treat them is to convert side-to-side anastomosis to end-to-end anastomosis. A bleeding can occur. Okay. Anastomotic bleeding. Anastomotic bleeding can be divided to early, within the first 24 hours, which is the most common, and which will stop spontaneously in the most of the cases, alone, without any intervention. Late anastomosis bring the suspicious of disruption of the anastomosis. So we should proceed for endoscopy. Most of the cases of anastomotic bleeding is unreported because it is self-limited. Okay. As when dealing with any lower GI bleeding, we start with resuscitation, fluid resuscitation, dealing with the coagulopathy, stopping any non-steroidal anti-inflammatory drugs. We may need blood transfusion, but if the bleeding persists, we may proceed, as we said, to endoscopy. And of course, endoscopy is easier to perform if the bleeding from the anastomosis in the left side. Yes, we can detect bleeding from anastomosis on the right side, but the anastomosis on the left side is accessible more. So this play a role in making our decision. Okay, you can see here the bleeding from the anastomosis picked endoscopically. What else? While we are using the endoscope, if we use endoscope, so the preferred method to stop the bleeding is by clipping. Yes, adrenaline injection, cauterization can be used, but clipping is more safe. The usage of one more information. While the endoscopist is proceeding the endoscope, he should be aware of air inflation, as we have anastomosis there. What else I want to add? That, as we said, most of the bleeding stops alone. Okay, there are other options such as angiography and surgery, but both are less preferable compared to endoscopy. The angiography carries the risk for ischemia, as we use vasopressin and embolization, so ischemia. Bowel preparation when we do endoscopy is not necessary actually. Okay, as we said, left-sided anastomotic bleeding is more accessible, so the threshold to intervene is lower. Okay, as we said again, injection of the bleeding with epinephrine can be done, but it carries the risk for ischemia. What else? If the bleeding does not stop with supportive medicine, with supportive measures, or does not controlled endoscopically as a third line, medical treatment, resuscitation, endoscopy as a third line, we proceed to limited angiography or surgery. With angiography, we use vasopressin or embolization to treat the anastomotic bleeding, but here we have a risk to compromise the blood supply. Okay, surgery may be better than angiography if the anastomosis is accessible, especially if the anastomosis is accessible. Okay, does that technique for anastomotic construction affect the bleeding? As we said previously, it is not statistically significant, but with a staple there is a slight but not statistically significant increase in the bleeding risk, but that does not mean that the hand sewn is preferred. What we should be aware when we construct the anastomosis is to do it in the anti-mesenteric side and to move the mesentery out of the field of the anastomosis. And intraoperatively, if we create a stapler anastomosis and we have to look inside after, for example, if we are going to construct side to side or end to end stapled anastomosis, look inside to see if there is any bleeding, and if there is bleeding, please do not use cautery to stop it. Use figure of 8 to suture and control the bleeding as this do here. Okay, in summary, as you see here, the true incidence of anastomotic bleeding is not known. Clinically significant bleeding is uncommon. Why the true incident is not known? Because most of the cases are unreported. Most will stop with supportive care, which may include blood transfusion. For bleeding that persists, endoscopic management is the preferred intervention. Anastomotic revision is reversed for the rare situation when endoscopic intervention failed. Anastomotic structure. Okay, structure usually, like bleeding, they are usually clinically insignificant. They are unreported because they are clinically insignificant. The most common definition used to define structure is that not allowing to pass a 12 millimeter colonoscope or rigid proctoscope. Symptoms can be constipation, cramping, or even decreased the caliber of the stool. The diagnosis is usually made at around 12 months if we are not talking about recurrent of a malignant disease. And what else? Of course, the structure can cause a problem when we are when we cannot go through it to examine the proximal colon. This is fact when we are talking about malignant disease or even for benign disease for surveillance. Okay, the more distal the anastomosis or the lower the anastomosis, the higher the stricture rate. So, for example, ilial pouch anal anastomosis and coloanal anastomosis have higher risk of stricture when we compare it to more proximal, such as the ileocolic anastomosis. Etiology, multifactorial. Of these are ischemia, infection, leak, radiation, recurrent of the disease. Proximal diversion is a risk in that it limits the passage of stool through the anastomosis, and the stool actually dilate the anastomosis regularly. And in this picture you see a fluoroscope that pick up the structure. Here is an endoscopy. These are the two modalities technique, the endoscope, but the endoscopist should be aware of the type of the configuration of the anastomosis. Is it side to side, end to end? Because sometimes he may miss the configuration with stricture. So, as you see here, blind end of the colon, dog ear mimicking stricture, but this is a dog ear due to end-to-end anastomosis. Okay, of course we should be aware of malignant fistula and biopsy should be done, and even if a high suspicious of malignant isate fistula, of malignant stricture, we should repeat the biopsy. In these cases, monitoring of the tumor marker CEA, PET scan can be helpful if we have stricture and suspicious of malignancy. Okay, this is an endoscopic imaging of hand sewing coloanal anastomosis that can be healed or treated with digital dilatation. In some low structure we can use digital dilatation but require repeated procedure and under even anesthesia. If it's successful, we can advise the patient to use the Hager dilator. Again, the most important thing in managing structure is to know, is this benign structure or malignant structure? Another modality in the treatment of the structure is the bougie structure, or as you see here, a balloon endoscopic view of a tight end-to-end stapled anastomosis and the dilatation with balloon and how it's finally. Actually, these structures which are available to be dilated by balloon, they are usually mild stenosis, mild from 10 to 12 millimeter, from 10 to 20 millimeter, and they are short segment. Another way to deal with the structure is endoscopically to do what we call it the endoscopic electrocautery incision. You see this incision done at the stricture site. These are like releasing incision to dilate the structure. We can proceed with self-expanding metallic stent, as you see here. Also, another modality for stricture is to use a circular stapler to remove the structured site and to resect the structure. Okay, this should be low. And what other, in general, you can see that those are located above 10 centimeter from the anal verge. We can use staple, the circular staple. Those are less than 10 centimeter from the anal verge. We can use hand sewing coloanal anastomosis. We resect and reconstruct. One of the surgery for structure that is low is the thrumpal structure. We bring the colon in a two-stage. We bring the colon out and we construct coloanal anastomosis again. Okay, what else? Let's see. In summary, clinically significant anastomotic structure will occur in only 10% of patients. Most of these, even 10%, are left-sided within the ring. And fortunately, many structures are simple and can be treated with dilatation using balloon or manually, while often successful. Repeated procedures are necessary. For those that fail simple dilatation, we go to incision of the structure endoscopically, followed by dilatation or transanal structuroplasty. Thank you, dear colleague. We have finished the lecture of anastomosis. See you in the next lecture. Bye bye.